Welcome to another Prisma Health Town Hall, and thank you for joining us. I'm Rebecca Munnerlin with the Prisma Health Media Relations team. As South Carolina's largest healthcare system, we're here to support your health and wellness and to ensure our community has the latest information on healthcare topics. February is American Heart Month, an important time to spotlight and discuss heart disease. Prisma Health has joined others in bringing awareness and providing educational information about heart disease, how to recognize the signs of heart failure, and how to take care of your heart. Today, we're closing out American Heart Month by bringing together a panel of experts, of Prisma Health experts, all-star team today to provide information on how to be heart healthy. With us today, we have Dr. Gautam Bhatia, Cardiothoracic Surgeon in the Upstate, Dr. Tara Holder, Interventional Cardiologist in the Upstate, Dr. Michael Cryer, Interventional Cardiologist in the Midlands, and Dr. Jared Sargeant, Interventional Cardiologist in the Midlands as well. Those of you following us on Facebook, if you have any questions you'd like to post in the chat, we will look at those and try to send you some answers through Facebook. So thank you for being here with us today. We're going to get right into our questions. I'm going to start with Dr. Bhatia first. Dr. Bhatia, what is coronary artery bypass surgery and why is this procedure done?
Yeah, so coronary artery bypass grafting is an operative therapy for coronary artery disease. A lot of times we see patients with coronary artery disease that can involve 1, 2, or 3, as we call them, main coronary arteries on the heart. When you have 1 or 2 blockages, stents are a great option for that. But when you have, usually when we say you have 3 vessel disease or a variant of that, surgery has usually been proven to be the best way to treat that. And essentially what we do is we create new pathways for blood to get to the heart muscle so that the heart muscle can stay stronger, longer, to allow patients to live longer.
So this prevents future heart attacks?
It's not guaranteed to. If you go back to an unhealthy lifestyle and you're not taking your medications and following up with your doctor, you can get progression of your disease in the native arteries or those new grafts. They can all get disease in them. It is a way to prevent it in the kind of immediate future as someone presents to the hospital with blockages. But it does not cure coronary artery disease. It is a way to prevent the repercussions of it.
And this is when patients are pretty far down the line with heart disease, so it's a pretty intensive surgery.
Any surgery, any heart surgery is a big deal. With technology and techniques, even coronary artery bypass grafting has become a little more commonplace and a little easier for patients to tolerate, but it's still having your chest open and it's still undergoing open heart surgery.
Thank you for that. Thank you for summarizing that for us. Next question is for Dr. Tara Holder. Dr. Holder, what is the difference between good and bad cholesterol?
I think when we think about good cholesterol, we're talking about HDL. And, in some observational studies, it was demonstrated that HDL at higher levels was actually protective against decreasing coronary artery disease. And so, we've gone back and continued to explore this good cholesterol model. And what we know for sure is that if your HDL, your good cholesterol, is pretty low, it could increase your risk of having heart disease. But as we've learned more, actually, is also is if it's too high, it could also increase your risk of having heart disease. So there's clearly some sweet spot that we're still trying to understand for good cholesterol. When it comes to bad cholesterol, we're talking about your LDL. And so that's, a cholesterol marker that if it is too high, it clearly increases your risk of having cardiovascular disease. So we're always trying to get that on the lower side.
That makes sense. Our next question is for Dr. Michael Cryer. Dr. Cryer, why are statins effective at lowering cholesterol? And once you start on a statin medication, does that mean you're going to be on that medication pretty much forever?
Yeah, that's a great question. So statins work on that bad cholesterol that Dr. Holder was just mentioning, though. We call that the LDL cholesterol product. And This number, if it's elevated alone can increase risk, especially if there's other risk factors, other, prior history of heart disease, peripheral disease, histories of strokes, uncontrolled blood pressure, diabetes, advancing age, all increase the risk of cardiac events. And having this high LDL or bad cholesterol number, associated with some of these things, can be bad. So we focus on trying to get that number down as a means to reduce future risk of cardiac events. That could be heart attacks or strokes. So statins are a tried and true form of medicine we use to accomplish that task. We have many different statins. We have different strengths. Some statins are stronger than others. And depending on the risk profile, will be more or less aggressive in getting that LDL cholesterol down. It works largely through an enzyme in the liver that allows the numbers to essentially come down. So that's the focus of statins. So that was the first question. Remind me, what was the second question you asked?
Once you start those medications, does that mean you're going to be taking a statin forever?
Correct. Not necessarily. Some individuals who may be lower risk, not the lowest risk, people who are extremely low risk for issues, we wouldn't really generally consider statins, but people who are sort of in that low to intermediate risk, if they, say they have hypertension and a mildly elevated LDL, say they put a large focus on changing lifestyle habits, weight loss, exercise, through diet and these means can sometimes get their LDL cholesterols down to, much more acceptable levels, levels that reduce that risk tremendously. And if we see that, it wouldn't be unreasonable to stop statins and see how things go. Some people who are at higher risk or people who have had prior events, say heart attacks or strokes, generally will be on some form of cholesterol lowering medicines, recommended essentially indefinitely or lifelong. There are alternatives to statins if they're not tolerated. Some people have side effects. We'll talk about that a little bit later, but sometimes we may, pivot to a different type of cholesterol lowering medicine if needed later on.
Thank you. Yeah, that was a big question that I had when I started on a statin a couple of years ago, was whether or not this was something I'd have to do forever. So changing over to Dr. Jared Sargeant. Dr. Sargeant, I don't know, can you tell us what the normal range of cholesterol is versus an abnormally high level of cholesterol?
Yeah, definitely. I mean, like my colleague said before, essentially, so total cholesterol, typically you want less than 200 is sort of what we aim for. Traditionally, LDL or bad cholesterol, we were less than 70. In recent time, guidelines have changed, particularly with our patients who've had coronary disease or had an event who've got bypass or stents. We're really now shooting for a goal LDL of 55 or less. So that's where statins and other medications come in. So those are sort of the numbers we shoot for. And, like I said, like Mike alluded to, statin therapy is not just about the numbers. Sometimes we achieve the numbers, but particularly people with coronary disease, there's an anti-inflammatory effect of statins, and we've treated people even beyond those numbers. But there is some imaging data as well about is too low a bad thing? And that's, I think, an area of continued research.
So I'm not aware that there's a home test to test your cholesterol levels, like testing for glucose. So does that mean you need to see your primary care provider? Are labs required so that you can monitor that?
Yeah, I think definitely, anybody in this category requiring statin therapy, not just for the numbers of cholesterol, but, adverse effects of any medication, check the liver function test, but having your cholesterol numbers checked to change medications or even sometimes change the type of statin is important. So anybody on these medications or with heart disease or high risk of heart disease definitely should be following with primary care and probably a cardiologist. Yeah.
Got it. Thanks for that. Changing back to Dr. Holder, let's see. Should you be concerned if you have swelling in your legs, and when should you see a doctor about what feels like sort of an abnormal look or feeling in your legs?
So, I think leg swelling is a pretty kind of complicated thing. Most of it is actually pretty benign. And the primary cause of leg swelling for anyone tends to be venous insufficiency, especially as we get older. But leg swelling can also be an indicator that something else is happening, that you now have heart failure or some sort of underlying liver dysfunction or kidney dysfunction, that something else is awry. So, I think overall, if you're noticing your legs are swelling, if things aren't getting better, they're getting progressively worse, you might have other symptoms that you're not sure are related. I think seeing someone for that sooner rather than later would be appropriate.
Is that, I mean, and that doesn't, we were sort of on that cholesterol topic. That doesn't directly relate to your cholesterol levels necessarily. That's a separate coronary issue, I suppose, in most cases.
Yeah, it's a very separate issue. What we were talking about with cholesterol, I tell my patients that's more of a plumbing issue, you know,
Got it.
versus, something that's swelling related to the heart, that might be more of a pump function, is something going on with how strong or how weak your heart is.
The muscle and everything
Yes.
related to that. Got it. I'm going to switch back over to Dr. Cryer. Dr. Cryer, if you've started taking statins and you're having difficulty with those, can you describe what some of the side effects from statin medications are and what folks' options are if they find that they're having trouble, if they have trouble tolerating those?
Yeah, that's a good question. One we get very often in the clinics with the folks that we're treating. This has been a very interesting topic, sort of as a prelude. This idea of myalgias, aches and pains that can come from statin medicines has been looked at for many years. And interestingly enough, in the literature, there's never been any proven effect on the injury to the heart muscle, the development or to skeletal muscle or development of myalgias. But anyone who's taking care of folks who take these medicines know that they end up with these problems, and it's very much a real problem that we see with the individuals who are on these statin medicines. Luckily, it's not very common, but for individuals it does occur too. It can be quite disrupting to their daily life. Aches and pains, legs, back, may not be uncommon. And ways we can try to get around that. We can try different types of statins. There are ones that are less prone, less notorious, I guess, for causing these side effects. So sometimes we will switch over to those. Try different ones. Some get broken down by different pathways in the liver, and maybe in certain individuals less aggressive for them. So we may try 2 or 3 different statin medicines to see if those symptoms improve. Some folks, more anecdotally, it's not really a lot of evidence to support this, but some people have tried coenzyme Q as a way to see, they would take this with their statin medicine to see if this helps. I've had some folks who've responded well to it. I've had some folks who haven't had that change in any of their symptoms. So if we've tried a couple of different statins, could the coenzyme Q is not helping. At that point, we usually try to get to a medicine that can lower the bad cholesterol. That's not a statin. So we have different types of medicines. There's ezetimibe, bempedoic acid. More aggressive lowering medicines are actually subcutaneous injections you get every 2 or 4 weeks. Those are extremely effective, can reduce the bad cholesterol numbers up to 70 to 80%. Whereas the other two, the ezetimibe and bempedoic acid, are a little bit more gentle in their cholesterol lowering. So sometimes we have to use both of those agents together to achieve the numbers we want to get. It's also important to mention LDL cholesterol may not be the end-all be-all on the risk profile that's associated with the development of atherosclerosis. It's something we know about. It's something we can measure, but there's a lot of research and data going into figuring out what other pathways exist that can lead to the development of atherosclerosis, because we definitely see folks who have high cholesterols and do fine and live their entire life and don't have problems. And we have some individuals who have very low cholesterols, and occasionally those individuals have issues with heart attacks or strokes. So there's things like, ApoB and Lp(a), very, boring scientific stuff, but just know, for the public out there, we're learning about other molecules that exist and may have treatments for in the future.
Thanks so much for that information. That's really helpful. Switching over to Dr. Sargent, let's talk a little bit about knowing your resting heart rate. I have one of these fancy smartwatches that I can press a little button on, and it'll tell me what my heart rate is, my resting heart rate, as well as my activity level heart rate. What's the best way to measure that? And are these smartwatches a good way to do it?
Yeah. So I think in modern times with technology, it's been great. It makes it a lot easier to get your heart rate. Heart rate is essentially measured in beats per minute. So sort of the old way to measure it would be to check your pulse, so feel your pulse and see how many beats in 15 seconds, multiply that by 4, which gives you essentially your heart rate, the amount of beats per minute. And so I don't know if there's a best way to check it. The radial pulse just at the right wrist would be an easy way to palpate and check manually. But I think the smartwatches and, smartphones of today do a pretty good job of giving patients good data. And even the modern automatic blood pressure cuffs give you a pulse that's pretty reliable.
So when a patient is coming in for a evaluation by you, and you, for instance, put them on maybe something like, I assume you all still do this, do like a treadmill test. Do you all look at how quickly a person's heart rate elevates from the resting rate to the rate when they're moving at a certain speed? Or tell me what you evaluate there.
Yeah, so I think heart rates, though they seem like a simple topic, they're very complex. I think what you described just now was something called heart rate variability. And heart rate variability is actually an important marker of cardiovascular reserve and fitness. It's very big in the sports cardiology world. Essentially, a better heart rate variability shows increased cardiovascular fitness. So high-end athletes, high-performance athletes tend to have lower resting heart rates, but their ability to jump from a low heart rate to a fast heart rate, like Usain Bolt, a sprinter, he could go from probably 40 beats a minute to 160 in order to accomplish his goal, his sprints. And so heart rate variability is important, and it is something that we look at with stress testing and cardiopulmonary exercise testing, which is an important prognostic marker of cardiovascular health. Yeah.
Got it. Thank you. No switching back to Dr. Bhatia, let's talk a little bit about surgery. Are there minimally invasive ways to have heart surgery now? What is the state of the art sort of way to get to that now?
Traditionally, and even today, sternotomy, or through the breastbone remains the main way that most surgeons around the country do heart surgery. There are minimally invasive options. You can go through the ribs to do certain valve operations and even some certain coronary artery bypass grafting. Robotic surgery has kind of become a big thing because of the way it sounds, minimally invasive, having it done by a robot. But a lot of those surgeries, you end up with a smaller incision between your ribs, but it turns out it can be more painful than your standard sternotomy. And you a lot of times have to have a way to get on the heart-lung machine. And so you end up with another incision in your groin or something like that in order to do that. So minimally invasive, everyone kind of wants smaller incisions, less pain. But a lot of times when it comes to heart surgery, smaller incisions can be more painful based on their location. But like I said, traditionally, it's been through sternotomy, and it still remains the #1 way that surgeons do heart surgery around the country.
Right. Let's switch gears a little bit with you, Dr. Bhatia, a little bit and talk about high blood pressure and what why that's bad for you, what the long-term effects of that can be.
Yeah, so high blood pressure, you know, is one of the medical comorbidities we can use to treat to kind of prevent progression of coronary artery disease and other arterial diseases. You know, whether it's patients with aneurysms, patients with coronary artery disease, we want to try and keep our blood pressure as well controlled as possible. That way we can prevent any kind of further deterioration down the line, whether it's just creating more stress on the wall of the vessel that can cause progression of disease.
Yeah, using Dr. Holder's terminology, I guess it can cause a plumbing failure pretty quickly. Yeah, good to know. Switching over to Dr. Cryer, let's talk a little bit about diet and its effects on all of these bad outcomes we're talking about, which to me, you know, having to have surgery feels, at least until you get everything fixed up, kind of bad. If you have high cholesterol, how do you advise your patients what would you advise them to try to stay away from?
Yeah, this is always a hot topic. You know, what is the best diet, you know, to reduce cardiovascular outcomes, you know, treat hypertension, treat cholesterol. You know, anyone who's paid attention to any of the, you know, things that come through on the, you know, Instagrams and Facebook, pages will see one article one day that says this food is bad for you, and then a week later it says this food is good for you, and it's a yo-yo. So there's a lot of, you know, information that's out there, and if you pay attention to it, you kind of walk away with more questions than answers sometimes. So you know, first and foremost, the reason these trials, these studies that people, you know, publish end up yo-yoing back and forth is because they all are being looked at essentially retrospectively. What that means is people are, you know, taking surveys, or they're looking backwards in time and asking people questions about what diets they use. And that is a very difficult way to gather information. It is very prone to bias, essentially. Somebody who eats a certain diet may also be prone to ride their bike a lot, or exercise, or not smoke. And we end up with what we call confounders, things that are not being studied, may be related to certain pools of patients. So that's why those studies bounce around back and forth. That's why some years coffee is good for you and some years coffee is bad for you. What do we generally recommend? What I generally recommend to my patients to control their cholesterol, I first and foremost recommend a focus on reducing carbohydrates. So that's sugars. Obviously sugar things, you know, the pastries, the desserts, the sweet drinks is a big one. The energy drinks and things like Powerade, Gatorade have a lot of sugar in them, what we call carbohydrates. Things that may have a lot of carbohydrates in them that are a little bit more subtle, or maybe you know, missed when people are trying to cut things from their diet, or what I call the white things. So that are, you know, that would be rice, potatoes, pastas, and breads have a lot of carbohydrates. So limiting that intake will reduce the risk of diabetes, and, you know, the things that can be related to the triglycerides and LDL cholesterol getting out of whack, that's related to diabetes and high carbs over time. There is some focus on limiting red meats. That probably is beneficial. We don't have a lot of great data to support that, but I think, you know, limiting carbs and watching your red meat intake would be generally pretty healthy. Trying to avoid excess salt is good for your blood pressure, and I think would be good for your arteries in the long term.
And I'm assuming fried foods kind of fall into one of those categories to moderate.
Probably that falls more in line with fats, and what fats are better than others. So, you know, a lot of those fried foods have what we consider to be unhealthy fats, and maybe a focus on healthier fats. So a lot of oils, you know, Mediterranean, you know, foods and oils are probably less inflammatory over time and can be better for you.
Gotcha. Thanks. Switch it back over to Dr. Sargeant. Dr. Sargeant, how does exercise help your cholesterol?
Yeah, great question. You know, especially if you want patients to exercise, they should know how it helps. But you know, going back to our topic about good and bad cholesterol. So first and foremost, the increased exercise and metabolism essentially improves the metabolism and transport of bad cholesterol, getting rid of bad cholesterol. So that's how it reduces that bad LDL number. Then there's the aspect of increasing your HDL, which is the good cholesterol. So it's all a balance. So exercising itself without getting too scientific reduces your bad cholesterol and increases your good cholesterol. There's also the aspect of depending on the type of exercise, cardiovascular exercise, obviously helping your heart function and strength. And then there's resistance training where you're bringing in more muscle groups, bigger muscle groups, and improving glucose metabolism and cholesterol metabolism. So exercise in general helps cholesterol in that way and overall your heart function.
For folks who are fairly mobile, what would be the #1 exercise you would recommend to them at any age?
The most convenient, honestly. I think when it comes to exercise, the key is consistency and just being consistent and doing it. I think there's been multiple studies over which is best. I think my advice is always for people to switch it up. You get bored with things easily. So a brisk walk, the American Heart Association and ACC recommend, 30 minutes of moderate intensity exercise for 3 to 5 days a week. But my thing is get up and move, do something every day, whatever is convenient. Sometimes that's a stroll around the block with your dog. You have low impact on the joints for people with joint problems like swimming, yoga. They're all also very helpful. And then, for the younger patients, HIIT training or high intensity training has good cardiovascular benefits as well. And like I mentioned, I think it's key to always bring in an aspect of resistance training because increased muscle increases metabolism and fat burning and glucose burning. So I think it's important to keep some degree of resistance training.
Great advice.
Mm-hmm.
Thank you so much. Well, switching back over to Dr. Holder, let's say you've started exercising and you're experiencing some leg cramps on a pretty regular basis. Is that a red flag for anything? Should I worry about having leg cramps if they occur with some regularity?
It could be. So, it's kind of interesting, but as cardiologists, people describe chest pain pretty similarly for the most part, like when they're describing that something is wrong in their chest. But, as a vascular and endovascular specialist, the variability with which patients describe leg symptoms is unbelievable. It is completely variable. So it might not just be cramps. Some people might say, my legs burn, or they think it's a hip issue. It's just the whole gambit. I think the consistency of it is that if something is happening with exercise that's stopping you from maybe walking around the block with your dog. So whatever that something is, however you perceive that, it could be an underlying vascular issue. And really knowing that kind of what your risk is of that. So in patients that have diabetes, patients who smoke, they're going to be at the highest risk of having cardiovascular disease, both heart and vascular issues. In patients who already have vascular disease, they might already see one of us because we've done stents in the past. They're also at high risk because, as I tell patients, the thing that gave you heart disease, it's not partial to just your heart. It's happening everywhere. So, like that could be an early signs of, do you have something called peripheral arterial disease? And if you did, then that would kind of change the way we approach your risk factor modification, and we would intensify it, and, there are other things that we can do to help improve your quality of life. So it could be.
Got it. While I have you, Dr. Holder, and following up on things we eat and drink, I wanted to ask you how alcohol can affect our heart health and things like cholesterol, and how you advise your patients who maybe they enjoy a glass of wine with their dinner, or or having some regular social outings. How do you advise them on their alcohol intake?
Similar to what Mike said, you read one year that wine is in, and then the next year too much wine is out. And so there's a huge fluctuation in the media about, is alcohol good or bad? I think the one thing that has remained consistent regardless of that is that too much alcohol is bad. And too much alcohol can increase your LDL and triglycerides. And so really wanting to limit your alcohol, especially if you're in this too much category, and just knowing what that means. So, for men, that would be 2 drinks, no more than 2 drinks a day. For women, 1 drink. And then they classify what is a drink. So just kind of knowing that, I think that's probably the most consistent guideline overall, is that too much is too much, and it can affect your LDL and triglycerides. As for how much wine you should and shouldn't drink, depends on what year and what you read.
Yeah, it always seems to be changing, doesn't it? It's kind of like dairy or no dairy. Okay, switching over to Dr. Cryer. Can we lower our blood pressure naturally without taking blood pressure drugs, or is there something that we can do to support that? So maybe we have to take less medicine. How do you lower your blood pressure naturally, if you, or can you?
Yeah, no, absolutely. It depends on the circumstances. Some people have bad blood pressure, and no matter what lifestyle changes they do, they require medications. If the blood pressures are extremely high, usually lifestyle changes alone are not going to lead us to the goals where we want to be. But for those in that mild to moderate range who have a lot of opportunity to make some changes, we can often get things controlled through exercise, weight loss. Especially abdominal fat, that intra-abdominal fat, pooches the belly out. That is a hormonally active. It's almost its own organ, and it can lead to a lot of issues. And blood pressure is one of them. We sometimes refer to these, constellation of issues as metabolic syndrome. So, trying to get that belly size down, and I usually tell patients sometimes 10 pounds to 20 pounds is enough of weight loss to get people off one medicine, to equate to one blood pressure medicine. So through diet, exercise, watching salt, as I alluded to earlier, would be ways to achieve that. We also like to look for other causes. Not all high blood pressure is just from, either genetics or obesity. Sometimes there are things that we have to screen for to figure out, that are also playing on in the background to cause the blood pressure to be high. Some things are artificial stress. Some people just get extremely anxious in general, or in physicians' offices. And what we see is white coat hypertension. It may not be real when they check their blood pressures at home or in less anxiety provoking situations. Pain is a big one. Those individuals who have chronic pain or fluctuating pain problems will often go through spells of having difficult to manage blood pressure. We like to look for more correctable things that lead to true high blood pressure problems, things like sleep apnea, thyroid problems, kidney problems. So your doctors may talk to you about screening for those particular types of things as well. And sometimes treating sleep apnea can lead to significant improvements in blood pressure alone without the need for medicines.
Interesting. Good to know. I'm going to switch over to Dr. Bhatia now. Let's talk a little bit about low blood pressure. When is blood pressure considered low, and why is that a problem?
So low blood pressure can kind of be variable from person to person. Some people just have low resting blood pressures that for them are normal, and they don't notice any symptoms from it. Patients can have systolic blood pressures in the 80s and 90s and live like that and not have any issues. We call it kind of normal blood pressure around 120 to 80, which is kind of our goal of therapy. But patients that have acute lowering of their blood pressure, sometimes it can be from starting a new medicine that's a little too strong for them. And a lot of times, when we start medicines, we ask patients to keep an eye on their blood pressure so that when we start something, we make sure we're not dropping it too much. And some patients are used to living at a higher blood pressure, and when you lower it closer to normal, they develop symptoms from it. They get dizzy, they get headaches, they don't feel very good. But we sometimes see an acute low blood pressure in a setting of a patient that's very sick, whether that's from infection or bleeding or even acute, we call it kind of heart failure and weakening. And those are problems that you have to be in the hospital for and treated acutely for. But it really just depends patient to patient what you call low blood pressure and what's symptomatic and what affects them.
Got it. On that topic, Dr. Holder, is if someone has what I guess the word might be chronic low blood pressure that needs to be treated, or how do you determine whether it needs to be treated and what is a potential treatment for that?
I think, like previously said, blood pressure varies from person to person. So just because we know of a quote normal number as 120/80 doesn't mean that everybody lives there. We'll see patients who are like, oh, my blood pressure is always low, and it's in the 90s, they're low 100s, and they're totally fine. And those patients, I would classify them as asymptomatic patients with low blood pressure. They have known low blood pressures, but they don't have any symptoms. They're going about their daily lives. They wouldn't even know it otherwise if somebody didn't check it. Those patients, I wouldn't do anything for. I think that it's just a number. They are doing totally fine and they're okay. For the patients that are symptomatic, I think that's the breakdown is then you have known low blood pressures, and every time you move, your blood pressure might drop even further. You get dizzy, you get lightheaded. Those are the patients that we want to be evaluated by their primary care or cardiologist just to figure out, why is this happening? Is it a new medicine? Like Dr. Bhatia said, is there something else going on that's driving them to have a low blood pressure all of a sudden? So I think that's kind of the way I classify it. Do you have symptoms or not? And for those that do have symptoms, then they should seek additional care.
Got it. Dr. Holder, while I have you, I thought I would ask, as so many of us have sedentary type jobs now, and also young people are on their computers more and more and don't go out and play even as children as much as we used to run through the woods when we were kids. Are you starting to see younger patients in your practice now that are having to think about these cardiac issues earlier in life than, a lot of folks associate first confronting these problems in middle age? Are you seeing younger patients now in your practice just because of the way our lifestyles have evolved?
Yes, I think across the board, every specialty is probably seeing younger patients. We know that we're getting younger patients with type 2 diabetes because of our sedentary lifestyles. And sedentary lifestyles lead to hypertension, obesity, people that have obstructive sleep apnea. So we're just seeing this build of comorbidities in a patient population that you otherwise might not have seen that in 15 or 20 years ago. And so it's a complete shift in the population you're seeing in your clinic, but also the way you're thinking about their comorbidities. Previously I would never think of a 30-year-old as having a heart attack. Now you might get a 30-year-old who's clearly having a heart attack because they have built up risk factors in a much younger age than previously thought. So yes, I think there's been a definite clear shift that these comorbidities are definitely affecting a much younger population.
Thank you. Dr. Cryer, going to stroke risk, we're seeing more strokes in younger people now too, aren't we?
Yeah, I mean, we're seeing a lot more what we call, MACE events or major adverse cardiovascular events, so heart attacks and strokes, in people in their 30s and 40s than we have probably the previous decade or two. Why exactly that's happening, it's not entirely certain. Some of this may be lifestyle, the greater risk of diabetes in younger individuals. There does seem to be an uptick that occurred around 2020, and since then, and we all know what happened then. So is there a relationship with COVID and post-COVID states with higher inflammation? We know other viruses like the flu increase risk for heart attack. It's been, we've all been dealing with this post-COVID world and seeing individuals who've had thrombotic events with this type of infection, and that includes heart attacks and strokes. So we'll, continue to try to focus on limiting those risks. Whether vaccines help or not, we'll have to continue to study that. But mitigating the risk factors with, healthy living, controlling blood pressure, controlling bad cholesterol and blood sugars will continue to be our focus.
Thank you for that. Dr. Sargeant, I'll go to you next for any final thoughts or words of advice on initiating some lifestyle changes that will do us all some good.
Yeah, I think the two take-home messages for me, and I always tell my patients, like, life is moderation, you know. Treat it like everything else in your life. You know, you do good, good comes back to you. The same thing with the human body, you know. You're never going to be perfect all the time, but you always shoot for perfection. You try to do the right things, make the right decisions. And the second message is, listening to everything today, you see how complex medical issues are, particularly cardiovascular disease. And this is why it's important to have a primary care doctor and to have a cardiologist if you need one, and to follow up, because, you know, it's not as simple as we think. And even within cardiovascular disease, you know, you have interventionist here, you have cardiothoracic surgery. Even amongst ourselves, we have our own specialties. So, you know, live a healthy lifestyle, be consistent, and follow up with your healthcare providers.
Got it. Dr. Bhatia, before folks have to come in and see you, what would your final words of advice be to our audience today?
You know, I think Dr. Sargeant really summed it up well there. You know, I like to say everything in moderation. You know, we all have vices, and you can only do so much to minimize those vices. But if you think about, you know, trying to do the best you can every day, move a little bit every day, exercise a little bit every day. You know, if you've got a sedentary job, walk around as much as you can, you know, in the middle, you know, in between work, and try to avoid seeing someone like myself or Dr. Holder. I mean, it's the best thing for you. So, you know, making healthy choices and making good decisions early, especially as the population gets more comorbidities earlier, is the best thing to do.
Right, and don't get too upset if your team is losing in the home game, right? Dr. Holder, any final thoughts?
I think reiterating what everyone said, you know, the reality is we live in an area that has a lot of diabetes, a lot of good food, a lot of tobacco at a young age. And I think just being aware that these things are there, and that, you know, we're trying to keep patients healthy and make sure that they're following up with us and following up with their primary care providers. I think that's as good as we can all hope for around here.
Got it. Dr. Cryer, I'll give you the last word.
Oh, I got a helicopter taking off right next to me, so I hope it's not too loud. But I just want to thank you guys for setting this up. I think it's always great to be able to reach out to the public. You know, we have a lot of you know, diabetes in this area. There's a lot of you know, coronary vascular disease. You know, that would be, you know, coronary artery disease, peripheral arterial disease, and strokes in this community. So everything we can do to get the message out there to reduce the risk of those events occurring, I think is for the greater good.
Thank you so much. We appreciate everybody tuning in as sort of one of our last installments in our Heart Month content this month. And we really appreciate all this great advice you've shared with us today. And I hope folks will continue to tune in to our topics that we have to help folks understand their health choices and their health resources with Prisma Health. So wish everybody great into their well, tomorrow's leap day, so enjoy your leap day for February tomorrow, and off to spring in March. Wishing everybody good health. Thanks so much.